So we'll move on to Rhonda Barcus, who is with the National Rural Health Resource Center in Duluth, Minnesota, and has been there since 2012, manages the Small Rural Hospital Transition Project, worked in hospital settings for 33 years. Rhonda's experience in leadership and organizational development, and has assisted hospitals to address organization-wide goals related to improving patient experience and staff retention. She received her Master of Science in Psychology from Georgia College and State University. She's also a licensed professional counselor and has a background in the field of substance abuse. So welcome, Rhonda Barcus.
All right, thank you so much. I am pulling up my PowerPoint. What an honor to be here today. Thank you so much for including me in this so that I could talk a little bit about the Integrated Behavioral Health Project, which is, we call the IBH program. And I'm very excited to actually get to follow Daryl because, you know, he talked a lot about the different about community health needs assessments, and this program with Minnesota was actually a result of the community health needs assessments in that state. And so I am really fortunate to work at the center with a group of really passionate and talented folks. We're a nonprofit that is dedicated to sustaining and improving healthcare in rural communities. We work on a lot of different areas, as you can see. As was shared, I work on the Small Rural Hospital Transition Project, which supports hospitals that are in persistent poverty counties. We work with the Delta states. We work with communities and networks just to improve coordination of care. So the IBH project was funded by the Minnesota Department of Health, Office of Rural Health and Primary Care, and this was part of a flex grant. And in Minnesota, the Minnesota Department of Health knew that they wanted to focus on population health. They knew that. So what they did is they went in and they analyzed the 59 community health needs assessments in their state, and they found over and over again that one of the two most frequently cited needs was for work around behavioral health. Specifically, they found that there was really the need to build those community partnerships and to integrate behavioral health and outreach. And so that's why the state of Minnesota decided to focus specifically on behavioral health. They also looked at their local public health department findings, and those findings were the same, that behavioral health was the main issue. And so what the decision then was to focus on integrating behavioral health with primary care. And why this is important. It's important because we know that when you integrate mental health, substance abuse, and primary care services, this is going to produce the best outcomes. And it's also the most effective approach to caring for people with multiple health needs. And so as we worked with hospitals, the hospitals that were actually going to participate in the project, the hospitals were focused on how can we really tighten up and create very strong care coordination practices, processes, so that we are supporting our folks in our community with behavioral health issues, so that they are getting such good support in so many different areas that they're not having to use the emergency department because now they're in a crisis. So the intention behind for many of the hospitals was, let's prevent crisis from happening for folks. We know who we need to work with, so how can we prevent that crisis? So that was one of the main pieces of that. What that meant is, you know, there was a lot of behavioral health work that was being done in the communities, but very often, as is true with many places, it was very siloed. And so different organizations were doing their thing, but not everybody working together. And so this project required people to come to the table, whether it was other providers, other organizations working with behavioral health, whether it was organizations that work to help with the social determinants of health. But it's bringing everybody to the table. And sometimes this meant competitors sitting at the table, but beginning to talk about how can we work together better to help the people in our community. So I want to start with the kind of the end piece. One of the end pieces of this entire project was the creation of a toolkit. And I'm just putting that up there so that you know that all the information I'm about to talk about, you can access in this toolkit. And as we were creating this project, we wanted to do two things with the toolkit. One is to really provide a lot of specific information that if anybody wanted to use this to address behavioral health in their community, they could. But we also wanted to create a toolkit that was generic enough that folks could also use the processes to perhaps address a different kind of population health issue, whether it's diabetes or heart disease. So I think that some of the processes we use could actually be generalized to other populations. So if you went on to the toolkit, you could see we talk specifically about our readiness assessment, how we selected the hospitals we were going to work with, what our technical assistance looked like, how we evaluated and looked at our outcomes. And then the toolkit below includes the specifics as far as the hospitals that we worked with. There's some really nice one-pagers and videos of some of the things that they did and their outcomes. So anyway, just kind of a nice one place to go and look at all the different pieces of this project. On the left side of the screen, you can see the state of Minnesota, and you can see the hospitals we worked with over the entire state. Originally the plan was to work with these three cohorts. We rolled out one cohort each year of hospitals, and we worked with three cohorts. We ended up creating a special project, which is called STIGMA, after those three cohorts completed, because one of the things we heard over and over again from the hospitals and their communities is that the stigma of mental illness, behavioral health, substance abuse, the stigma of all of that was one of the biggest barriers that was getting in the way of really good community care coordination. And so we had decided to do a special project to just address stigma, which I will describe a little bit later. Here you can see, if you clicked on technical assistance, you would see some of the things that we did. We had a kickoff workshop where we brought all the hospitals together. We went on site to each individual hospital in the cohort and did community strategic planning. We did quarterly peer calls where all the hospitals in that cohort were on the call together so they could share their accomplishments. What were their barriers? What were their challenges? And then they could do a lot of sharing and kind of brainstorming together of solutions. And sometimes one hospital would know of something that was out there that the other hospital didn't know about. So there was a lot of that peer work. We did quarterly evaluation calls, which I'm going to talk about in just a moment. And then we did just technical assistance as needed, educational webinars on different topics. And then we would bring everybody together again, one more time, all the hospitals in that cohort, to talk about sustainability practices. I want to talk a little bit about the evaluation process that we use. This is something that we created at the center several years ago. So it was prior to the IBH project, and we used this process to evaluate many of our projects. And we call this the recommendation adoption progress. What we know is that measurable outcomes are important. We need to be watching those. We need to be tracking changes in measurable outcomes. And we also know that that data only tells a piece of the story. And that's what I love about this process that we created, that it's also about telling the whole story. So quarterly, we will meet with the hospital and we will have a conversation with them. We don't send them a survey, we have a conversation and we talk about what's going well. And okay, what specifically did you do to actually implement that? And how did that happen? And we dig into the details of the story because that's really where the richness is, that we can then create kind of a picture of this project for this hospital so that other hospitals can take a look at that and say, oh, that's what they did. These aren't just the outcomes, but this is what they actually did. So we do that quarterly. Each quarterly wrap conversation picks up where we left off last time so that over the course of a year, we have the story that's told over that whole year. The other, I think, beautiful piece of doing these wrap interviews is we work exactly where that hospital is, and so sometimes we'll get on a wrap call and they will say, you know what, we haven't done a lot this quarter. You know, we've got this going on, we got distracted. So we use those wrap interviews as a way to talk about, okay, so what is the next step? And so what are you going to do? And you know, it's never failed that even if somebody gets off track, the next wrap call, they're back on track. So it's a way to hold accountable, and it's also a way to energize the project, because frequently I will hear folks on the wrap call say, oh my gosh, I did not realize we were doing so much work, until they start telling their story. So that's the wrap call, the conversation. Of course, we also have the data sheet, and for IBH, we have areas that folks will need to create measures for, but we do not require specific measures. We let the hospitals decide what their measure is going to be based on what's the population they're working with. You know, are they focusing just on people between the ages of 30 and 55? Are they working just with they're looking at behavioral health with just their seniors, or people who have a diagnosis of just depression? So they create measures based on their population. And so, for instance, a hospital-specific utilization of service measure might be, we want to measure how many people with this diagnosis are reporting to the ED each quarter. So they're counting those. And then the hospital-specific cost. Okay, so for these 50 people that presented to the ED in this quarter, this is what the cost was for us. So they create their own measures, and then during that wrap call with us, they share the measures, and then we talk about them and perhaps discuss about, you know, what's that measure about? What are you finding there? This is just an example of one of the hospitals we worked with. They were working, of course, to reduce the ED visits, and you can see very nice how it decreased over time. That's not always typical. We know that some have spikes at different times. But so in addition to just decreasing the ED visits, they also really wanted to focus on the inmates in their local jail, because they found that those folks were often having depression and anxiety, and then they were coming to the ED. So this hospital created a roving therapist who would go to the jail to counsel the inmates with depression and anxiety, as a way to try to address the issues so that the person did not have to get to the crisis point of coming to the ED. The roving therapist also could work with that person to make sure that if they were on any meds, they had what they needed when they left, so that they didn't have just a supply for a month and then they went off their meds and then they were acting out and they were back in jail or at the ED, but they actually had more of a long-term care plan with support systems in place. So this is just an example of one of our projects. Here are some of the measurable outcomes that people tended to look at: increased access to behavioral health care, increased discharge to home. So instead of having so many folks having to go to inpatient settings, it was seen as a victory to be able to have more people being discharged to home instead of inpatient. Fewer mental health holds, for instance, ED visits and admissions. So those were some of the measurable outcomes. Here were a few promising practices. These are some of the specific things that hospitals did that they felt made the biggest difference. One is the stakeholder collaboration. That was huge, because again, this is where they brought everybody together to the table and worked together, and it was not just the hospital. As Daryl mentioned, that's when it really works the best. Resource directory. Very often they've started this program thinking they needed more behavioral health resources. Sometimes that was true, but very frequently they found that they actually had what they needed. It's just everybody was in a silo. Nobody knew what the other one was doing. And when they started getting to the table, they're like, oh, I didn't realize you were doing that. So they created a guide and a directory so that consumers and providers knew what was out there. A couple hospitals created a universal release of information where they had all of the organizations as potential parts of their release of information, and then the patient could say yes, 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 all of those are fine for you to talk to. Mobile crisis team, client transport vehicle. Two hospitals actually talked about the huge cost to their community because they were using the police to transport their patients to an inpatient mental health facility, and a couple hospitals were able to work through the legalities, and they got a donated former police car, and they worked it out so that they had their own transport. And then the Make It Okay campaign, which I'm going to mention again in a moment. Here's some videos I encourage you to take a look at, just to go back and say a couple things about stigma, because again, this was huge. We gathered some of the hospitals that really wanted to work on this. They created a vision, and their vision was they wanted to eliminate stigma of mental illness and substance abuse, not just decrease it, but eliminate it. Here's some things they did. The Make It Okay campaign, again, the link is there for you to take a look at if you're interested. That was very powerful. But the other thing they did, once again, is they partnered with their community. And so some of the obvious ones, the schools, churches, businesses, but the really powerful piece is they often collaborated with the music, art, and theater in their community. And they created productions that would bring people together, whether it was music or art or theater, that really helped to address the stigma of mental illness. So again, finding some of those non-traditional partners was very important. There's some ideas for you, and then I have some links on the PowerPoint for different resources. And that is it. So thank you so much for letting me speak a little bit about the IBH project, and I look forward to hearing our next speaker. Thank you.